Hello everyone, it's Beth. I am presenting this as a education for both nurses and providers regarding bone health strategies in patients with multiple myeloma. This is part of my Doctorate of Nursing Practice Quality Improvement project, and the goals of this project are to increase appropriate prescribing practices for BTAs such as zoledronic acid and denosumab, increase patient reporting consumption of calcium and vitamin D, and then increase safe exercise practices in this patient population. I want to thank so many of you already for helping out with this project. It's going along great, and this is just the next step. So this is a modified education to provide better education regarding skeletal related events, supplement recommendations, and exercise recommendations for our multiple myeloma patient population. So skeletal related events are any type of injury, cord compression, anything requiring radiation or surgery to the bone, skeletal pain, or hypercalcemia that is a complication due to multiple myeloma cancer or any type of cancer, but specifically we'll be focusing on multiple myeloma patients. And for most of our multiple myeloma patients, bone pain is a presenting symptom for these patients. And a further 60% of these patients develop fractures after diagnosis, which is one of the reasons that we recommend starting a bone targeting agent such as zoledronic acid or denosumab. SREs decrease patient function, they increase pain, they also increase anxiety and depression, and the severity of the bone disease is correlated with tumor burden and then inversely related to prognosis. So that's why the International Myeloma Working Group strongly recommends that all patients with myeloma start a bone targeting agent such as bisphosphonates or denosumabs. Nationwide, only about 45 to 64% of our multiple myeloma patients are receiving this. Luckily, at Rocky Mountain Cancer Center at Lone Tree, prior to the start of this project, about 75 of our patients who were eligible were receiving some type of bone targeting agent. So keep this in mind when you see your patients, that according to the International Myeloma Working Group, all patients, regardless of whether or not they currently have bone disease, should be on a bone targeting agent. One side effect of this is osteonecrosis of the jaw, so it's important to have them educated regarding this and also educate them on the basic dental care. So for patients who are on bone targeting agents, they should have a dental examination prior to starting a BTA. And then for zoledronic acid, consider holding for 3 months prior to and 3 months post any dental extractions if possible to prevent osteonecrosis of the jaw. For denosumab, the recommendation is to hold for 30 days before and then do not restart until the extraction site has healed. For osteonecrosis, it does take about 4 months to heal. Significant pain, decrease in eating habits, and PO consumption, so this is a very significant side effect for most of our patients. Now, after a patient is, or if a patient is diagnosed with osteonecrosis of the jaw, if the patient does heal after that 4 months, you can restart a bone targeting agent, but only address this in a case-by-case basis, as many patients and providers are hesitant to do this. Supplements that we are recommending with bone targeting agents and with multiple myeloma patients include calcium and vitamin D. So only recommend calcium supplementation after the normalization if your patient was diagnosed with hypercalcemia. Obviously, we do not want to overload them with more calcium. But both the International Myeloma Working Group and also the drug inserts for denosumab and zoledronic acid recommend supplementing with calcium and vitamin D. You'll see the total values based on age and sex listed here, and you really should not try to exceed 2,000 milligrams of calcium a day. So a safe recommendation for patients is to supplement with 500 milligrams a day at least. And most of our patients do need a little bit more than the average person, but we don't want to exceed that 2,000 milligrams. With vitamin D, this should always be assessed prior to starting a bone targeting agent and then again periodically about once a year to make sure our patients are not vitamin D deficient. You'll see the deficiencies list here, but less than 10 is severely deficient, 10 to 30 is considered insufficient, and then greater than 30 is considered sufficient. Deficiency is correlated with an increased number of plasma cells in bone marrow, but there is no correlation with multiple myeloma activity or presence of lytic lesions with vitamin D deficiency. One study did show that vitamin D supplementation can increase erythrocytes and hemoglobin and leukocytes, so that was an interesting finding in one study. And there are some studies to suggest that being vitamin D deficient while you are receiving chemotherapy can increase the risk of neuropathy. So if we're testing for vitamin D in our patients and we find that they are vitamin D deficient, supplementation can be beneficial on a variety of levels. It can be notoriously difficult to get vitamin D testing, as our lab team will testify. So this is a list of some ICD-10 codes that you can utilize to help get vitamin D testing, including disorder of the bone, hypocalcemia, hypercalcemia, obesity, long-term drug use, long-term use of bisphosphonates, etc. Vitamin D deficiency, if patients are deficient, consider treating with 50,000 international units for 4 to 8 weeks and then recheck afterwards. Multiple myeloma patients may need more because they are utilizing more of this vitamin D as they struggle with bone disease. And patients over the age of 70 may also need supplementation. In general, it is safe to recommend that 1,000 to 2,000 international units of supplementation is safe for your patients, as most of us don't get it through either sun exposure due to sunscreen or winter weather, as it's currently snowing outside. We're just not outside enough and we're not exposed enough. And then foods that include high vitamin D include fishes, but a lot of people aren't meeting those recommendations, especially if they're currently being treated for cancer with chemotherapy as well. It is difficult to overdose on vitamin D, however, it can happen, but in general, that happens around the 3 million international unit mark, not at a low dose of 1,000 to 2,000 units per day. The third thing that can help our patients prevent skeletal-related events is actually exercise and physical activity. And this can be a difficult thing for a lot of us to talk to our patients about, but exercise in general has been shown to improve fatigue, cognitive impairment, can also decrease depression, pain, anxiety, and fatigue. Some studies have shown that exercise can improve overall cell count, including hemoglobin, and it can actually help decrease complications of like dose delays and dose reductions and increase the completion rate of chemotherapy treatment for our cancer patients. Increasing muscle mass can also increase volume of drug distribution and decrease some dose-limiting toxicities that we see. And of course, our main goal here is strengthening the bones of our patients. There are some barriers that do come up when we discuss exercise. So a lot of patients actually want to discuss an exercise or physical activity program with their providers, but they want their providers to initiate that conversation. They're afraid to do it themselves. But on the flip side, only 28% of oncologists report that they initiate conversations about physical activity, and that 60% of providers just don't even discuss this at all. Other barriers include patient fear of injury, symptom burden, and especially neuropathy. Some tips on writing an exercise prescription for patients as a provider. So when you're discussing exercise with your patients as a provider, consider discussing the frequency, the intensity, the time, and the type. So FIT, F-I-T-T. So frequency, recommend that they start low and go slow. So if they are doing no physical activity right now, something safe to recommend might be, that they walk to the end of the block or they walk to the end of the driveway twice a week. Just start with something very, very simple. It's low intensity. It's walking, that is the type. And then the time, maybe that takes them about 10 minutes. Recommend about 10 minutes of activity to start with, a couple of times a week. And then recommend that they slowly increase this, either in increasing the frequency or increasing the time that they are doing, but not both at the same time. So if your patient is walking for 10 minutes twice a week, maybe in a few weeks they try walking 3 times a week for 10 minutes. Or they keep the twice a week, but they increase to 12 minutes or 15 minutes. So just consider slow increases each time. There are some special considerations in multiple myeloma patients, such as their lesions. Are they on upper or lower? Are these lesions stable versus unstable? Do you need to refer them on for surgery or radiation? Do you need to reassess where these might be? What is your patient's baseline? So if we're talking about a patient who tends to be very sedentary and has not performed any exercise, let's start with a very slow 10-minute walk twice a week recommendation. But if this patient has previously been playing golf 3 times a week, you can recommend something like bicycling or something slightly more intense, or they do 30-minute walks to start with. Do they have neuropathy? So we're looking at risks for falls, for dropping weights. So recommend if they are going to be lifting any weights that they use a machine if they have neuropathy, or be standing like over a bed or something where if they drop the weight while they're lifting with their arms, that safely falls onto the bed and not onto their foot, causing more injuries. And then, of course, do they have any other comorbidities? Are we talking about heart disease? Are we talking about diabetes? And being aware of this. Also consider current steroid use, as this can weaken bones further. Sometimes providers have difficulty starting the conversation, so things like, what does your typical day look like? Do you spend most of it in bed? Do you exercise? If so, how many times a week? Asking about what activities they do enjoy or what are they able to do now. And then what are their goals? Are they wanting to improve mobility and balance? Do they want to start bone strengthening? And then what would help them start an exercise or increase? What barriers might be in their way? Here you'll find a list of recommended restrictions. So if patients are fevering, if they have a very low hemoglobin, less than 10, recommend that they do shorter intensity or less intensity for exercise. For fevers or vomiting or diarrhea, recommend that they don't do any exercise for 48 hours until they recover a little bit more. We already talked a little bit about neuropathy, but also considered that treadmills or ellipticals should be avoided with neuropathy just because of that movement that could cause more injury. We discussed a little bit about bone mets, but patients should avoid trampolines, HIIT training, or jumping. If they have an ANC less than 1, recommend that they avoid public gyms or swimming pools. Of course, a private gym at their own house is okay still. And then being aware of PICC lines, trifusions, etc., avoiding hot tubs and swimming pools. And if their platelets are less than 50,000, avoid exercises that increase their risk of falling. So maybe not bicycling, but walking instead, walking in a safe area, watching out for ice, etc. Don't forget to turn to our PTOT colleagues to refer them to. So consider a referral to improve balance to prevent falls. Did the patient have a recent hospital stay? Are they deconditioned? Are we looking at cancer-related fatigue? Again, that can be helped by exercise, but they might need some help starting. Does your patient have pain, neuropathy? Are we getting them ready for a transplant, pre-transplant treatment, or pre-cancer treatment? Strengthening the bones and the muscles prior to this can actually help complete treatments. And then cognitive dysfunction can also be a referral reason for PT or OT. Local support oncology rehab here in town can be very helpful with helping out our patients. And then I also found a group called Luna, which is an app that patients can download, and they can find their own physical therapist who can come to their home. And this is frequently covered by Medicare supplements. So this could be an option for our more tech-savvy patients. I've included a list of references here as well. Next steps. So our next steps, most of our patients have already received a handout called Bone Health for Multiple Myeloma Patients. Those who have not yet received it in the office will be receiving a mailed copy here. Our request for providers is to continue to think about bone targeting agents if your patient is not on one already. And then when you are talking to your patients, discuss calcium and vitamin D supplementation as well as exercise. If your patient is taking calcium or vitamin D, please document it in the medication list in iNomed 2. And if they are exercising, please just mention that in the HPI because that's how we are extracting that data. For more information, consider checking out some of the following resources. The myeloma group through the United Kingdom actually has some great handouts And then I've also attached some videos here that can recommend exercises to our patients, and these were included in their handout as well. And then Exercise Oncology by Catherine Schmitz is a great resource if you are interested in discussing exercise more with your patients. Thanks so much. Have a great day. Oh, sorry, if you have any more questions, don't forget to contact me. And then please, please, please complete the survey. This is linked here in the PowerPoint, and then will also be in the email. Providers will get an additional survey later on asking if you have noticed a change in the amount of time that you are talking about with your patients and if you are seeing any skeletal related events. Thanks again so much.